This presentation will examine the prevalence and implications of malnutrition in children afflicted with cancer, as well as intervention methods for health professionals. There are few things in life that are as tragic and heartbreaking as a child diagnosed with a life-threatening illness. In the United States alone, approximately 10,400 children under the age of 15 were diagnosed with cancer in 2007, and approximately 1,545 of these children passed away from the disease. Although this makes cancer the leading cause of death by disease among children, advances in medical therapy and disease management have made long-term survival much more achievable. The overall cure rate for childhood cancer now exceeds 70% and is projected to soon reach 85% in industrialized nations. Therefore, major attention is being placed on reducing the side effects of therapy, such as malnutrition. Studies actually suggest that up to 46% of children with cancer experience malnutrition. Malnutrition is characterized by either a deficiency or an excess of energy with measurable adverse effects on clinical outcome. It's also really important to point out that while energy, meaning calories, is the key component of malnutrition, vitamin and mineral deficiencies also greatly contribute to overall malnutrition and health. Children with cancer are particularly vulnerable to malnutrition because they require additional nutrients in order to obtain proper growth and development and to fight off their disease. Before we take a look at the causes of malnutrition during childhood cancer and the corresponding side effects, I think it is important to understand how to assess the nutritional status of a child. There is currently no consensus on how to define malnutrition in children, but the most common practices involve plotting weight to height ratios. Weight and height are usually plotted on standardized growth charts. Once a child's placement has been determined on the growth chart, this number can be converted to what is known as a z-score. A z-score is a numerical summary of each child's placement relative to a reference population and are used to compare and assess data between different ages and genders. Once a z-score is determined, the child can be placed on what is known as a standard normal distribution graph. This graph puts the average variable that is being measured in the center of a chart. Any child whose height or weight z-score is more than 2 standard deviations greater or less than the mean is considered to have significant growth abnormalities. Thus, if the child fell 2 standard deviations below the mean, he or she would be considered to be malnourished. However, studies have shown that simple weight-height measurements are often inaccurate depending on the type of tumor, such as large solid tumors. Other practices include tracking voluntary food intake and comparing intake to the required or recommended guidelines. If the child were eating less than 70% of his or her estimated energy requirements, he or she would be considered malnourished. Another way is to take anthropometric measures of the tricep skin fold thickness to determine adipose or fat energy reserves. If less than the 5th percentile for age and sex, the patient would be considered malnourished. This is an example of a standardized growth chart. This is an example of a standard normal distribution graph. If a child were malnourished, the child's weight would fall 2 standard deviations below the mean, where the circle is drawn on this graph. All children are at a time of rapid growth and development, and because of this, it is important they receive enough calories and nutrients. For normal children not battling illness or disease, 4 to 8-year-olds need approximately 1,600 calories, 15 grams of protein, which is equal to about 2 eggs, and 800 milligrams of calcium, which is equivalent to 3 1-cup servings of low-fat milk. As children age, their calorie, protein, and calcium needs increase until they reach adulthood. Children undergoing treatment for cancer are also experiencing rapid growth and development, but they have an even higher need for nutrients because of an increased metabolic rate from fighting the disease. Both protein and energy needs are increased even more to prevent wasting or the loss of muscle. Protein needs actually increase the most, with recommendations that children receive up to 2 grams per kilogram of body weight each day. Increased calcium and vitamin D needs are also critical due to bone growth during childhood. Children should consume more than 1,000 milligrams of calcium, which is equal to about 4 1-cup servings of low-fat milk, and more than 10 milligrams of vitamin D, which is equal to about 10 to 15 minutes of sunlight. Each day, this will ensure that their bones will continue to grow during disease treatment. Calcium is needed to help the bones grow and remain strong, and vitamin D is required to ensure that calcium is absorbed. So what causes malnutrition during cancer? Malnutrition arises in children for one overall common reason: an inability to consume or digest food and nutrients. This inability to consume or digest foods has many underlying causes, but we will discuss two of the main ones today: the side effects of chemotherapy and other aggressive treatments, as well as the increased metabolic demands from the cancer itself. Most malnutrition occurs as a result of the intense cancer treatments such as chemotherapy. Chemotherapy kills rapidly dividing cells, and in effect damages cells lining the intestines. This makes the intestines unable to absorb nutrients and food. Anorexia, mucositis, which is the inflammation of the mucous membranes lining the digestive tract, vomiting, diarrhea, and alterations in taste are important side effects of chemotherapy that also contribute to weight loss and malnutrition. Because of these side effects, cachexia can often result. Cachexia, also known as the wasting syndrome, can result in extreme cases. Cachexia is the loss of weight and the atrophy of muscle, resulting in an intense fatigue and weakness. It cannot simply be reversed by eating more calories because lean body mass is also lost. To avoid cancer cachexia, it is extremely important for children to eat enough protein and calories throughout the treatment. The type of cancer itself plays a role in malnutrition as well. In fact, it has been well documented that certain tumors and stages of diseases are associated with an increased risk for becoming undernourished. In a study conducted in 2011 by Bauer and others entitled Important Aspects of Nutrition in Children with Cancer, different types of cancers were compared and their corresponding risk for becoming undernourished were assessed. Overall, malnutrition was more prevalent in children with advanced solid tumors such as neuroblastoma, in aggressive tumors, and in tumors in the later stages of malignancy. Undernourishment was seen less frequently in children diagnosed with non-metastatic tumors and diagnoses with a more favorable prognosis. We will now turn our attention to the side effects and problems malnutrition causes during cancer treatment. There are many side effects that malnutrition causes during cancer treatment. However, we will focus on three key side effects: an increased treatment time, a decreased quality of life after survival, and a greater chance of becoming underweight or overweight later in life. Studies have shown that malnutrition reduces the effectiveness of chemotherapy, thus increasing the length of time children must spend being treated in the hospital. Being malnourished also increases the likelihood of developing an infection due to a weakened immune system. Malnutrition has also been proven to lower the overall quality of life and lower the chances of a patient's survival post-treatment. In children, undernourishment has a significant role in survival rate, especially in children with solid tumors and metastatic diseases, which are children at a high risk. Many studies have also shown that survivors of specific cancer types are more likely to cause a child to become underweight or overweight later in life if the child experienced malnutrition during treatment. Children diagnosed with soft tissue sarcoma, neuroblastoma, non-Hodgkin's lymphoma, brain tumors, male survivors of leukemia, non-amputated females with bone cancer, Wilms tumors, and survivors of Hodgkin's disease are more likely to be underweight later in life, whereas children diagnosed with acute lymphoblastic leukemia and those receiving cranial radiation therapy for brain tumors were at a higher risk of becoming overweight and even obese. The reasons behind these trends are still being researched. However, possible implications associated with being underweight include being malnourished while receiving total body irradiation, treatment with abdominal radiation, and being at a very young age when treatment begins. The use of erythrocyclines and atinomycin, which are powerful chemotherapy drugs, are also associated with becoming underweight later in life because they cause structural and functional injuries to the gastrointestinal tract, preventing an adequate oral intake even later in life. This chart gives an overall comparison of the short-term and long-term consequences of malnutrition during childhood cancer. The ones that we've already discussed are bolded, and some other important consequences include the wasting of muscle and fat mass, drug dose alterations, retardation of skeletal muscles, and even an increased risk for secondary cancers. So clearly, avoiding malnutrition during treatment is extremely important. We will now turn our focus to the nutritional interventions that can be used to avoid malnutrition. We will now turn our attention to the nutritional intervention methods most commonly used in a clinical setting. There are three main feeding practices used in healthcare facilities: supplemental or oral feeding, enteral or tube feeding, and parenteral or IV feeding. Oral feeding is the best method of support for patients with a low nutritional risk. Some children will still require dietary supplements due to an increase in nutrient needs, such as calcium. Ideally, there should be flexibility in menu choice and meal times. Studies have shown that a more flexible meal service can lead to a significant increase in children's food, protein, and energy intakes. Enteral nutrition is a practical method when oral intake and the weight of a child continue to decrease. Enteral nutrition works well if the child's gut is still functioning properly. Enteral feeding also has the advantage of preserving the integrity of the intestinal mucosa. Parenteral nutrition is best used when the child's gut is no longer functioning correctly, thus bypassing the usual process of eating and digestion and feeding the child intravenously. Research has indicated that when normal oral intake is not possible, enteral nutrition has more physiological benefits compared to parenteral nutrition, including the maintenance of the heightened activity of intestinal villi and brush border enzymes, better preservation of specific gut nutrients such as glutamine and short-chain fatty acids, and an upholding of the mucosal membrane surrounding the intestine. Enteral nutrition is also associated with fewer infections and complications. However, many studies are continuing to show that parenteral nutrition is more successful at preventing and correcting malnutrition. In a study performed by Carl Braunschweig and colleagues in 2001, researchers looked at the cases of 27 cancer patients and examined the relationship between nutritional intervention methods, meaning if they received enteral or parenteral nutrition, and compared these feeding methods to complications and mortality rates in order to determine whether results supported the use of enteral nutrition instead of parenteral nutrition for patients suffering with cancer. The results of the studies showed that enteral nutrition or tube feedings were associated with a significantly lower risk of infection overall. However, in the studies with which patients had a high rate of protein energy malnutrition, such as cancer cachexia, there was a significantly higher risk of mortality and infections with enteral nutrition rather than parenteral nutrition. Parenteral nutrition was thus determined to be the preferred route of treatment when patients are malnourished. While these practices are best used during cancer therapy, we will now focus on nutritional intervention strategies for after therapy. Once children have entered remission, nutrition rehabilitation may still be needed in order to get the child back into normal feeding and eating patterns. Some of the side effects of chemotherapy may still exist. These side effects, such as diarrhea, constipation, sore mouth, weight loss or poor appetite, and poor digestion, can often be combated nutritionally. For instance, if a patient is suffering from diarrhea, kid-friendly foods that children would benefit from in this state include applesauce or other ripe fruits and vegetables, because these foods contain high amounts of pectin, a water-soluble fiber that can form a soothing coating in the intestines. Yogurt, because it contains beneficial bacteria to the gastrointestinal tract, and high-sodium soups and crackers, because this sodium helps the body retain water loss during diarrhea and helps prevent dehydration. There really can be a wide range of nutrient deficiencies, but there was a very recent study done that actually took a look at the diet of childhood cancer survivors in order to establish what nutrients they were deficient in. In a 2011 study entitled "The Dietary Intake After Treatment in Childhood Cancer Survivors," the diet of 50 childhood cancer survivors was assessed with a 3-day food diary recorded by their parents. This was done to see if there were any specific nutrients that childhood cancer survivors were lacking specifically. Of the 50 childhood cancer survivors, 20% of the participants were overweight or obese, 54% were consuming above their estimated energy requirements. More specifically, the 3-day food diary revealed that 50% of children did not meet their requirements for folate, 32% of children did not meet their requirements for calcium, and 44% of children did not meet their requirements for iron. This chart shows the 3 main nutrients that childhood cancer survivors were deficient in: folate, calcium, and iron. This chart also compares their deficiencies to a normal children's diet. As you can see, both children diagnosed with cancer and normal healthy children are deficient in calcium, whereas childhood cancer survivors are also uniquely deficient in folate and iron. These nutrient deficiencies can have negative health implications later in life. So what can we conclude from the study? While this study showed that 32% of childhood cancer survivors are not meeting their requirements for calcium, other literature suggests that up to 68% of childhood cancer survivors are not meeting the guidelines for calcium intake. This population is at a greater risk of developing complications related to osteoporosis because their cancer treatments may have altered their bone metabolism, interfering with their ability to obtain peak bone mass during growth. While treatment greatly affects children's overall bone mineral density, it is a multifactorial process, and adequate calcium intake, especially in the form of dairy, as well as weight-bearing exercises, can help prevent complications such as osteoporosis and help kids obtain a peak bone mass. The 50% of children deficient in folate are also at risk for long-term health effects. Many studies have shown a direct link between decreased folic acid intake and increased levels of homocysteine accumulation. In the body, folate acts as a coenzyme and participates in several single carbon transfer reactions, such as the synthesis of components in DNA, RNA, and proteins. Homocysteine is an amino acid that, under normal conditions, is converted to methionine with the help of folate. Thus, when folate is lacking in the diet, homocysteine levels build up, which is not good. Increased levels of homocysteine are associated with increased risk of heart and blood vessel diseases such as arteriosclerosis and blood clots. Children should consume dark leafy green vegetables which are rich in folate to prevent this deficiency. Many fortified foods such as fortified cereals, breads, or pastas are good sources of folate as well. Iron deficiency can be very dangerous in children. Iron has several vital functions in the body, including carrying oxygen to the tissues from the lungs in the form of hemoglobin. The direct consequence of iron deficiency is iron deficiency anemia. Symptoms include fatigue, weakness, and hair loss. The best source of iron in any diet is red meat. However, sometimes it's hard for kids to eat a lot of red meat. Another alternative to this is to have children take a 1-a-day supplement that contains iron. Quality supplements should meet 100% or less of the RDA for that nutrient. So in conclusion, malnutrition should be avoided in children receiving cancer treatments. The common causes of malnutrition include the chemotherapy and other aggressive treatments, as well as the increased metabolic rates due to the specific types of cancer. Going along with this, the side effects of malnutrition included increased treatment time, a decreased quality of life after survival, and a greater chance of becoming underweight or overweight later in life. While enteral nutrition is the best form of nutritional support in most cases, parenteral nutrition has been shown to be the best for reversing malnutrition. And finally, after undergoing cancer treatment, children are usually most deficient in folate, calcium, and iron, meaning dietary intervention should be taken to counteract. Thank you all for listening. I hope you have enjoyed the presentation and learned something.